Morning everyone, I'm Dr. Nandhitha Srivedhi and the topic for my presentation is Unmasking Metastatic Lung Cancer through Orbital Apex Syndrome. Financial disclosure, nil. Orbital apex syndrome is a rare ocular condition which has life-threatening complications. It can be either due to the mass effect on the structures traversing to the orbital apex or due to direct infiltration of these structures. Common etiologies include inflammation, infection, trauma, neoplasm, iatrogenic. Case details. Our patient was a 60-year-old female who presented with sudden onset painless diminution of vision and inward deviation of left eye since 1 week, and there was associated fever, headache, vomiting, tingling sensation over the left cheek, and pain in right lower limb which was radiating to the right hip. On general physical examination, multiple nodules on scalp and dorsum were seen, enlarged lymph nodes were observed, and there was decreased proprioception along the ophthalmic and the maxillary branch of the trigeminal nerve. And there was hyperreflexia in bilateral knee and ankle joints. On ocular examination, vision in the right eye was 20 by 30. In the left eye, it was hand movement close to face, PR inaccurate. RAPD was noted in the left eye. And on extraocular muscle evaluation, on Hirschberg test, there was 15-degree esotropia noted in the left eye and limitation of left eye extraocular movement in levoversion, levo-elevation, and levo-depression. And anterior segment and fundus evaluation were normal. Investigations were carried out. On blood investigation, increased ESR was noted, decreased TSH, T3, T4, FSH, LH was noted, and increased serum ACE was noted. CSF analysis was normal. On radiological investigations, on contrast enhanced MRI of brain on orbit, asymmetric hyperintense enhancing lesion of the cavernous sinus was noted, which was advancing towards the orbital apex, as we can see in the figure. On PET scan of the whole body, active soft tissue density lesions in the left lung with metastatic lesions in the brain, scalp, and the lymph nodes. And on HRCT chest, soft tissue hyperdensity in the left lower lobe was noted. FNAC of the nodules was done, and this showed mucin secreted adenocarcinoma, following which ultrasound guided biopsy was done, and this showed atypical cells in sheaths and nests with few signet ring cells, which was suggestive of adenocarcinoma, and tumor markers CA125 and CA were positive. We initially had differential diagnosis of systemic infection with CNS involvement. However, the CSF analysis was normal. We suspected sarcoidosis because serum ACE was increased. However, the HRCT tests were not suggestive of it. And idiopathic inflammatory disorder and thyroid eye disease were considered differentials. However, the radiological findings were not suggestive of it. And a provisional diagnosis of primary lung mucin secreting adenocarcinoma with systemic metastasis to the CNS, scalp, and orbit was made. The patient was referred to oncology department for further evaluation and radiotherapy was planned. However, the patient declined and she was kept on palliative care. Outcome, the patient succumbed to her illness secondary to septic shock and multi-organ failure within 1 month of presentation. We should have a high index of suspicion and for recognizing the prompt identification of the cause, and detailed and meticulous medical workup is essential with multidisciplinary team approach management. Take home message. Orbital apex syndrome due to orbital metastasis can be the primary presentation in case of lung cancer, and it is associated with grave etiologies that warrant a meticulous workup, and a multidisciplinary team approach is needed. Thank you.
So wonderfully worked up case. So it was nicely worked up. Dr. Shelja, I skipped few slides, so you asked.
No, it was well presented. I think all of the cases, they are actually similar.
Same,
And
yes.
just underscoring the need for a good imaging in these cases, picking up the signs and going in for a good imaging. Most of the time, you may have to then refer them to subsequent specialities because it's not really under an ophthalmologist's armamentarium to treat all these, but picking it up is what lies, the onus lies with the ophthalmologist. So well presented.
Thank you.
Ma'am, orbital apex syndrome is a rare condition, but here it seems like it's the most common occurrence.
So I think
Right.
yes, all the residents must have now come to know that orbital apex can present with varied presentations, and it is the workup which matters. The sequence, how you evaluate the patient, and then you can easily come to know what is the diagnosis. But if you mess up with the investigations, then it's difficult to come to the conclusion what it is.
Thank you.